which used this new kind of staircase recruitment maneuver and a decremental PEEP trial to go along with that, showing overall not only no benefit, but a potential harm signal for the high PEEP recruitment group. I think this study has to be taken in context with everything else we know about lung recruitment maneuvers and higher PEEP. And we note the fact that they weren't actually very successful in getting a lot of incremental recruitment because the change in driving pressure was pretty minimal. And it may be that complications from their very aggressive recruitment approach and a prolonged sustained inflation maneuver outweighed any small potential they had with this difference in driving pressure. In other studies, we've seen, in fact, that this is a sustained inflation recruitment maneuver and higher PEEP from the LOVE study, showing significant decreases in patients who died from refractory hypoxemia in the higher PEEP and recruitment maneuver group. And although it's true that each of these individual studies, Alveoli, Express, and LOVES, not one of them showed a statistically significant benefit individually, when you put all the patients together and analyze them in such a way that you look at patients with what we'd now call moderate or severe ARDS, there is a signal for benefit. But in the patients with mild ARDS, PF ratio 200 to 300, there's a signal for harm. Again, this idea about heterogeneity of treatment effect and us being careful about what we're subjecting our patients to. And again, this comes back to the golden question of who should we do as recruitment maneuvers? Well, of course, those who are recruitable. How do you know who's recruitable? This is the million-dollar question in ARDS. But this the Gagnoni paper here is instructive in that, I think. Here's a patient, a stereotypical patient who was a high recruiter. And you see going from 5 to 45 centimeter water, lots of lung opening, baby lung much bigger. We're all feeling good about this, oxygenation better. Here's the typical non-recruiter. The thing to notice here is that how different the starting CT scans looked. They didn't have a lot of patients who were socked in and had terrible looking chest x-rays and terrible CT scans that they couldn't recruit. The people who didn't recruit had most of their lungs open to start with. Obviously, you're not going to be able to recruit this patient very much because they don't have a lot of lung collapse. So how to set PEEP higher may be better if the patient has more severe disease. And if you think that we should be using higher PEEP in patients who are more recruitable, then somewhat unexpectedly, or certainly unexpected by some, it seems that titrating PEEP according to severity of hypoxemia, that's the LOVES approach here, was the only one of these different approaches, the Express trial, the using the stress index or using esophageal pressure, that actually led to us using higher PEEP in patients who were recruitable and lower PEEP in patients who were less recruitable. You also might, when you're thinking about, maybe I want to do some personalized medicine, you might want to look for an individual response to PEEP. Ewan Gallagher did this analysis, again, using the LOVES and also the Express paper data, and look to see what happened to the change in oxygenation following the change in PEEP at the time of randomization. So some patients had their PEEP increased, some patients had their PEEP decreased, according to both what they were on before randomization and the randomization scheme. And he looked and saw what happened to their PF ratio at the first blood gas after randomization, about an hour and a half afterwards. And it turns out that if your PEEP was increased, there was a strong relationship between your PF ratio change and mortality. If you had your PEEP increased and your oxygenation improved, significantly lower chance of dying. If you had your PEEP increased and your oxygenation got worse, mortality went up, suggesting overdistension in that scenario. And as a control, in patients whose PEEP was the same or decreased, there was no significant relationship with that short oxygenation change and mortality. Now, prone positioning is another thing that we should be clearly thinking about in a patient with refractory hypoxemia. From the first randomized control trial in the New England Journal in 2001, we already saw that in most patients, a robust improvement in oxygenation upon putting a patient prone. So really, if a patient's dying of hypoxemia, this should be something that we're strongly considering. And in patients with severe ARDS, we first saw a meta-analysis signal towards benefit and a subsequent confirmation in a prospective trial, taking the more severe group, proning them for 16 hours a day, getting them, and then stopping as soon as that was safe to do so, a significant improvement in mortality. And even if you think this, oh, this is too big of a difference to be really true, even if we halve that and say, well, maybe the real effect is only 8%, that would still be a very big absolute risk difference in mortality. Nitric oxide is another tool in our toolbox to help treat hypoxemia, a selectively selective pulmonary vasodilator when you give it in the inhaled form. And again, robust data to say this is effective in improving oxygenation. We don't use this in all patients with ARDS because there's no outcome difference when you give it to all comers, and in fact, the point estimates are all sort of on the wrong side of that line here. But for selected patients who you think are really dying of hypoxemia, inhaled NO may be a useful thing to buy some time. Now, alternative modes of ventilation. Before we get to ECMO, some people would promote airway pressure release ventilation or bilevel, depending on how you set this up. There are different ways of doing APRV, where in all of them, the common thing is that this is just two levels of CPAP. There's a low level and a high level. The patient can breathe spontaneously in between times, and usually there's no support for those spontaneous breaths. And at least sort of in the North American trauma surgeon way of setting this up, patients spend more of the time at the high pressure with intermittent releases to the low pressure to facilitate ventilation. So among APRV enthusiasts, there's often lots of sort of evangelical zeal saying, well, we can deliver higher mean airway pressures and recruit the lung and do so in a safe fashion, and we're facilitating spontaneous breathing. There improved less sedation, improved hemodynamics. We don't have to worry about synchrony. This is just CPAP. And maybe the patients are still using their diaphragm. We might even be preventing ventilator-induced diaphragmatic injury as well. But I have to say, I have some concerns about APRV from a mechanistic standpoint. I worry about overstretch with release volumes, which, depending on how you set this up, if you put P low very low, that may result in release volumes of 700, 800, a liter. And people say, oh, don't worry, it's a release volume. Well, it's true, but when you go back up to P high, most of that release volume is going back in again. So I worry about tidal volumes of a liter, even if it's only 8 or 10 times a minute. I also worry about overstretch from sort of, this would be patient self-induced or ventilator-assisted patient self-induced lung injury when you're holding them at P high and they're making their own inspiratory efforts on top of that may be raising their transpulmonary pressure significantly, and we have no way of measuring that unless we have an esophageal pressure balloon in. And I also worry about de-recruitment and reopening injury with releases, even if expiratory flow doesn't go to zero. I think the summary about APRV is that there's lots of enthusiasm in some corners, but not a lot of clinical or experimental data. Up until recently, there have been several smaller trials which mostly looked like this, showing no differences in clinical outcomes, no changes in PF ratio or applied PEEP. You may have seen one recent trial in intensive care medicine last year, a single center study from China, randomizing about 140 patients to APRV or volume cycle assist control ventilation using the ARDSNet outcome, and they showed very impressive outcome differences in mortality and in the primary endpoint of ventilator-free days at day 28. So I think these results are hypothesis generating and need confirmation in a larger multi-center study before we would adopt them, because there are some baseline differences favoring the APRV group. Tidal volumes were high in both groups. There were higher airway pressures in the APRV group, and the volume control patients were more deeply sedated, received more benzodiazepines and opiates, all of which may have contributed to worse outcome. So a question mark still. Finally, a couple of minutes about high-frequency oscillation. This is a different mode of ventilation that allows you to apply a relatively high mean airway pressure, which is functionally equivalent to PEEP, and then sort of magically shake the patient to get rid of CO2 without having to instill a large tidal volume on top of that higher airway pressure. Overall, when you apply this to patients with moderate to severe ARDS, as we showed in our trial and the UK study also showed, there's no benefit. And in fact, there may be a signal to harm. But for the patient with refractory hypoxemia, we have some new data that was just published in the Blue Journal last year, which shows that there is significant heterogeneity of treatment effect for HFO versus protective conventional ventilation based on the severity of baseline hypoxemia. So for patients who had a PF ratio less than 100, the point estimate favoring HFO was less than 1, meaning that HFO was better than conventional ventilation. If you want to be more conservative and say, I really want to see I want the whole 95% confidence interval of that line to be under 1, then it's PF ratio less than 61. So again, we're talking about our difficult to oxygenate patients. And so while this, this again, maybe some hypothesis generating data, I think it allows us to at least feel good about treating that patient who's dying of hypoxemia with HFO if needed, if they've already in the prone position and already on high PEEP and are not responding. So overall, I've tried to highlight some of the things that we can use in our treatment of hypoxemia before we jump to ECMO. We highlighted higher PEEP, prone positioning. Those are both, I think, well proven and actually can improve mortality in the right patients. HFO, APRV, inhaled nitric oxide, other things that we might consider. Again, go back to this physiology schema when you're at the bedside thinking about how can I help this patient and how can I individualize my therapy to improve their outcome. And with that, I'll stop there. Thank you very much.